To partially sunny San Diego, as Brian Clay mentioned in the chat. May actually rain here this afternoon, although at the moment it's just a little bit overcast. In any case, behind me you can see the partial sun in San Diego. It's always a pleasure to be part of this group, and very much look forward to hosting the group from Germany, Austria, and the European Union in San Diego this summer. I'm optimistic that this summer we'll be able to get together again in person and really.
Wonderful.
Yes, fingers crossed, but I'm pretty optimistic about that. So we'll see. So anyway, I'm here to begin with a little bit of a historical background about digital transformation in the United States and sort of what were the motivations to get it started. And so here's a schematic or a photograph, I'm sorry, of the University of California campus in 2019. Just last year, there are no new buildings at the moment. Our main medical center is right in the middle of the picture. And you can see in the far background the Pacific Ocean. And to the left, which you can't see too well in this photograph, is actually Mexico. So we're in a very interesting part of the United States in the very southwestern corner, which makes us unique in terms of some of the activities we can have both cross-nationally, but we're also really an internationally renowned center for science and technology. So, you know, the background to digitalization in the United States really began with the financial crisis of 2008, when, as part of the stimulus bill, when we were in severe financial straits, as was the rest of the world, a very wise decision was made, which was to spend some of the stimulus money on really healthcare transformation, and that included digitalization. It sort of makes one jealous for those days now when stimulus money has been partially put into the economy, but with no really strategy as it was back in 2008, 2009. So that really led to the major move forward in digitalization in the US. The American Recovery and Reinvestment Act was part of it. Some of you may have heard of HITECH, which is a Health Information Technology for Economic and Clinical Health Act. And that was really implemented in 2 ways. For Medicare and Medicaid, which is a major federal government insurance program, got involved in defining how electronic health records should be used, and then they built in financial incentives to back that up. And then the Office of the National Coordinator also established certification criteria for electronic health records in order to make them certifiable and to allow them to participate in the incentive programs. So at the same time this was all going on, it was on the tails of the Institute of Medicine publishing a couple of monographs. This is just one of them you're seeing here, Crossing the Quality Chasm, really sort of sounding the alarm in the United States that, you know what, we think we have a great healthcare system. In many ways, we do have a great healthcare system, but our quality and safety did not correspond to often our inflated opinion about how we were doing in healthcare. And this was really a wake-up call for medicine and for the nation in general, and for policy makers also. Here's a slide, many of you may have seen it before, that really sort of puts this in context. This is a couple of years old, but is really relevant today. You can see that the red line in the middle is the United States, and our expenses are high, and our quality, by the way, isn't all that great. So, you know, some of us might say that, well, if our quality of healthcare was so spectacular and our average length of stay, our average life expectancy was significantly higher, and our infant mortality rate was significantly lower than the rest of the world, maybe it's worth the cost. But in fact, it isn't better, hasn't gotten that much better. And in fact, our average life expectancy in the US has fallen slightly in the last couple of years for a variety of reasons. So nonetheless, with the advent of really wide dissemination, with the financial incentives that were put into place in 2008 and really sort of took effect over the coming years, it led to virtually all medical centers, all hospitals becoming digitalized because of the financial incentives. And most medical outpatient doctor medical offices, ambulatory practices became digitalized also because doctors also had financial incentives tied to getting digitalized. So what did that lead to? It led to what now we're in the midst of, which is a movement called value over volume, value being defined as quality plus service over cost. This is something that has become sort of a call in the United States for healthcare transformation. Has been a bit disrupted in the last year because of COVID. Well, I'll talk about COVID in a minute. But also the other leap was in data and big data, and I think others are going to talk about that this morning, population health, and then, as I said, the universal adoption of electronic health records. And in some ways, maybe the biggest thing that happened was the advent of consumerism. Quality and cost data became readily available on the internet. Social media became the source and the nidus for a lot of health information, and non-traditional healthcare encounters and patient experiences such as telemedicine became much more available. I can tell you as a continued practitioner of primary care, it is rare that I see a patient that comes in to see me without with a complaint, a medical complaint, where they haven't already gone to the internet to pretty much tell me what they think is wrong with themselves. Sometimes that's accurate, sometimes it isn't. But nonetheless, it is definitely here to stay. So this is just one example of what I mean by consumerism. This is a report card put out every year by the state of California that actually ranks by stars, or use what you want, but it's a rating system that's very easy to recognize. This is a rating system that is just for San Diego County. So these are the major healthcare providers in Southern California, San Diego County. This exists for the whole state of California. And if somebody is coming into the area or looking for a new healthcare provider, maybe is thinking about switching, they can look at both quality of care and also patient experience ratings. And as I said, this gets put out every year. You can dig down into more specifics about this. So this is what's made. So you might say, well, what do you really mean by value-based medicine? It's medicine where there's a measurement going on. Electronic health records have made transparency much more readily available. Doctors who went into medicine because they thought that they could practice with great level of autonomy, all of a sudden are being very surprised that autonomy more or less doesn't exist so much anymore in a digitalized world. So the reports on value of care reimburse providers based on value of care. Many of our contracts in San Diego are now based on value rather than just quantity. And I'll show you another slide emphasizing that. So improve quality of care by reducing costs or increasing quality. That's easy to say, hard to do and harder to demonstrate, but it is a goal. And basically this, by the way, was sort of the heart of what's known as Obamacare, which is to move away from healthcare based on quantity of care provided to the quality of care provided as measured by quality and divided by cost. So in a traditional healthcare system, fee-for-service payments were common. Now many of our contracts are paid for performance. We're at risk, we take financial risk. There's shared savings, but there are also penalties if we don't meet the contracts. There's a focus on, in the old days, traditionally focus on quantity, as I said before. Now there's a focus on quality of services. Traditionally, length of stay reduction was a goal. Now it's balancing length of stay and readmission reductions. It really has to do with, goes back to quality. Index admission focus, traditionally, now it's episode of care. Long-term focus, really the whole life cycle of a patient and their family and their community is really what we're looking more at now. Individualized patient utilization and costs. Now we're looking at population health and what is the cost of care and the quality metrics that we use for things like diabetes care and cardiovascular care and so forth. So how did COVID change things in the US? And this is according to me, but others will, I'm sure, weigh in this morning. Proliferation of telemedicine, no doubt. We went from a country that was dabbling in telemedicine, I'll put it that way. There were some certainly niche areas where it was common, but in general, telemedicine came to life in COVID. And in fact, you could say that it was So timing is everything, and timing was right for telemedicine in March. I'll show you a little bit of data from our place. But in the middle of March, we went from very little telemedicine to about 90% telemedicine within weeks. It was really quite remarkable. Unfortunately, there's been an avoidance of health maintenance and prevention. I think that that's not just in the US, but it's certainly been in the US. There's a lot of data about that. Patients are just afraid to access the healthcare system. So we know that unfortunately people are delaying things like mammography and colon cancer screening and things like that. However, there is a role of digital health in that we've generated a lot of registries for our patients. So we know who hasn't gotten a colonoscopy or colon cancer screening in a much easier way than we had ever in the past. So we're, unfortunately, when COVID is winding down and people start accessing healthcare in the way they did pre-pandemic, we expect an increase in later stage avoidable diseases, which is quite unfortunate. Diminished confidence in science and scientific evidence. That unfortunately is a result of our political environment over the last year, if not longer. There's an unclear, and partially because of that, there's a very unclear vaccine uptake interest in the US right now. I always ask my patients, and I saw patients yesterday afternoon, when the vaccine is available, will you get vaccinated? And I'm quite surprised at how many people are very standoffish about wanting to get vaccinated. The other unfortunate event is that many small medical practices and small hospitals, if they haven't already, will go out of business because of financial hardship, which has been quite dramatic in many parts of the United States. So the COVID-related telemedicine leap, which, as I mentioned, was really substantial. It really wasn't motivated by technology. The technology for telemedicine has been with us for quite a long time. At least in the US, it was really motivated by policy and by really patient and doctor demand for social distancing. To the right, you can see Joe Califano. He's our medical director of our cancer center. He's also he's a world expert on head and neck cancer. He transitioned to telemedicine very early on, especially for all of his follow-up visits, and he does telemedicine with patients around the world. So what happened that created the policy changes? So CMS, the Centers for Medicare and Medicaid, waived their restriction on payments for telemedicine prior to the pandemic. They weren't reimbursing widely for telemedicine. They had severe restrictions on it. They also took the restrictions off of telephone calls. They waived rules across the state. It's a longer conversation, but in the United States, we don't have one medical license. You need to get licensed in every single state where you see patients. So I have a license in California, but if one of my patients happens to be in Arizona, I actually legally can't see them because I don't have an Arizona medical license. That has been waived, at least for now, but it doesn't waive the liability issues with cross-state telemedicine. Again, a longer side conversation. These are all waivers, they're not laws. They have not put into law yet, although some of that is coming, and there has been a little bit of, I do think that post-pandemic, there will be some laws put in place, and these waivers, some of the waivers will probably go away. Social distancing, as I said before, really motivated this too. Patients didn't want to come in, frankly, at least back in March, April, May, doctors didn't want patients to come in. And we really, as I said, we went from a very low telemedicine rate to quite remarkably high. So not much new technology. There's been some, but it's really the application of the same existing technology. Here's a UCSD health success in 2020 with telemedicine. The top set of bars are, you can see that the number of arrived visits and then the total of telemedicine visits. So about 31% of our visits went to telemedicine very quickly. Down below is the date ranges, March 16th through the middle of November. So this is pretty recent data. We've gotten a steady state to about where a quarter or so of our visits are telemedicine. I think that we will settle into that percent even post COVID for reasons of convenience and economy also. Telephone visits, there are some video visits that fail, and so we convert those to telephone visits. And over this period of time, about 5% of our visits were by telephone. We obviously prefer, for multiple reasons, to have them by video. So this is, so we had the opportunity to write about this also. And on the upper left-hand corner is a paper that Dr. Meyer and I wrote actually about 10 years ago at this point, about when we started our telemedicine program. And the one down below is a paper we wrote. It was published in August. This is really about our March and April experience of how we went from very little telemedicine to sort of 60 miles an hour really quickly. This was a large group effort. You can see Brian Clay's name there and Chris Longhurst also, who you know, who participated in this really multi-dimensional effort to stand up telemedicine really overnight in a substantial way. So the potential telemedicine pitfalls, it's not a panacea. There are issues with telemedicine. One is maintaining the patient-doctor relationship, and we know that in standing up telemedicine in our organization, but it's been written about places also, that there is a technology divide, that older patients are disadvantaged, maybe lower socioeconomic classification patients are disadvantaged. They may not have the hardware or the software available to do visits. And so we have programs in place where we're trying to distribute some equipment to patients who need it, who may not have the capability of using it. One of the benefits that we had very early on in March when the pandemic started, we tried to transform ourselves to telemedicine very quickly. We also had a bunch of medical students who all of a sudden didn't have any classes to go to. So we actually enlisted medical students to help educate and train some of our more technology challenged patients to learn how to use it. That actually was a real panacea for us, and we were very lucky to do that. Engaging patients, I don't see this as a pitfall. I actually think it's an advantage. We're transforming ourselves to making home blood pressure monitoring available. That's easier said than done. There are some pitfalls with that. One advantage is being able to see into patients' homes, which is, I find very, very interesting. You get an idea of where patients live, what their environment looks like. One of my doctors had the experience of talking to one of his diabetic patients while the patient was drinking a sugar cola. So obviously realizing that more education needed to be done. We're trying to avoid creating more extra provider work. This is always a balancing act to integrate telemedicine into the daily routine, so it's not additive is very important. And as I mentioned before, we're not using medical students anymore, but to have staff coach and tee up patients so that doesn't become a burden for doctors themselves. And then actually a major, I think, looming issue is to not build walls between EHR systems. So in the US, there's been a proliferation of standalone for-profit telemedicine providers who have their own electronic health records, but in terms of how they integrate with our bigger health system EHRs, is problematic. And as a provider myself, I just hate having to look in multiple places for patient information. So to sum up that last slide, we actually, Lisa Rottenstein from the Brigham and I published a paper that came out just recently in the Harvard Business Review about how to avoid some of the telehealth pitfalls that we actually experienced with EHR. So what lessons could be learned from an EHR so that they don't get repeated with telemedicine. So hopefully, what's the future going to bring in the US? And I'm wrapping up. I just have one more slide after this. So returning trust in the government and public health, I think we're about a month away from returning of some trust in the US healthcare system, especially the CDC, the Centers for Disease Control, and the Federal Drug Administration also. And I think that the last year or so, I think the world is already judging us very harshly. Internally, I think we're judging ourselves very harshly also. I think there'll be a return of globalization. We're all connected in fighting things like pandemics. There'll be a new debate over insurance coverage, as there's been 4 years of trying to remove Obamacare, which was not successful. There'll be a widespread adoption of telemedicine, remote monitoring. And as I said, the remote monitoring is going to proliferate. And telemedicine, I believe, will end up being about a quarter to a third of all of our ambulatory visits. New knowledges of viruses, and I'm talking about biologic viruses, although the way things are going with computer viruses too, prevention and treatment, The role of the federal versus state and local public health decision-making, I think, will continue to be debated, and hopefully we will be drinking wine rather than bleach. This is a little bit of an old quote. You may remember back several months ago when Donald Trump raised on national, if not worldwide TV, why can't we try drinking bleach as a way to prevent COVID because it worked on cleaning instruments and so forth. So one of my favorite slides is, and one of my favorite quotes is, change happens at the speed of trust. Before we can really make a lot of difference, I think we need to restore trust in the healthcare system. We need to restore trust in the Centers for Disease Control. We need to restore trust in the federal government, in the White House, in major decision makers at the federal and at the state level, but mainly at the federal level. So the arrow is pointing in the right direction. This is the direction we're going. I think we all took a huge sigh of relief a few weeks ago when our election was over, and I think we're on the right track. But we have a lot of ground to make up. And that's my last slide.